Robert Verheij, responsabile del NIVEL, che è una sorta di CNR olandese, per i database per la medicina generale.
Ciao tutti, and thank you very much, Franco, for inviting me here and also for introducing me to the Italian cuisine, to be more precise, the Veronese cuisine yesterday. I never had so much meat in one day, and it was delicious. Really it was, and also the Valpolicella, if I pronounced that right, was very, very, very good, and it kept me awake for quite a while last night. But this is not what I want to talk about. I'm going to talk about NIVEL Primary Care Database, and I wanted to start my presentation with a question. How many people have diabetes? How much of the population in Italy have diabetes? Does anyone know? 5%. Okay. That's a little bit more than we have. Here you have figures from our website, which say that T90, that's the ICPC code for diabetes, is 4.5 incidence and 66.3 prevalence per 1,000 patients listed in general practice. I'm not going to go deeper into this, but this is just an example of what we can do with NIVEL Primary Care Database. Another question, how many people have depression? You don't have to raise your hand here, but it's a similar question as I had regarding diabetes. Well, I'm not going to wait for the answer. The incidence is 7.6 and a prevalence of 34 per 1,000. Well, other things are, which other health problems do people with depression have? Well, a lot of comorbidity there. I'm also not going to go deeper in these results, but just to show you what we can do. This is another example. How often do people with diabetes consult their GP? Well, 12.4 consultations per year, and less than half of that is really for diabetes. And this is very important for people in the ministry to know that all the diabetes people do not only use care for diabetes, but also for other things. As I said, I'm going to talk about NIVEL Primary Care Database, which is a research infrastructure that is based on electronic health records. My name is Robert Verheij. I'm program leader at NIVEL, and NIVEL stands for Netherlands Institute of Primary Care Research. I am not a doctor. I'm a geographer, social geographer by training, but I've been doing health services research since 1989 or so. So in that 1980, yeah. So that's more than 25 years now. What NIVEL Primary Care Database is not, I find that very important to stress in this presentation, because I know you have discussions with your ministry or your regional organizations about sharing data coming from general practice. So I want to stress what we are not doing. It is not a system to exchange information between health professionals caring for the same patients. We have systems to do that in the Netherlands, but it is not NIVEL Primary Care Database. It is also not a system covering all primary care practices in the country. It's just a sample, a representative sample. It is also not a system for reimbursement of GPs. These are three things that are very essential for the rest of my talk, which is essentially about trust. But before going deeper into the subject of trust, I think it is good for you to know what are the goals of NIVEL Primary Care Database. It is to monitor developments in public health, to do surveillance of infectious diseases, to describe developments in health service utilizations and workload of general practices. It is designed to deliver representative data on the quality of care of health services. It is designed to measure effects of policy measures and to provide data for other institutes, universities, etc., that want to do research with this data. Before I carry on, I think it is also important for you to know a little bit about the basic characteristics of the Dutch healthcare system. We have, like in Italy, we have a gatekeeping role for GPs for specialist care. So you have to have a referral before you can enter the secondary care system. There's also a list system, which is also similar to what you have in Italy. So that makes it very easy to have an epidemiological denominator. In terms of reimbursement, there is a mixed system of capitation and fee-for-service. There's a capitation fee of about 55 euros per year, and for every consultation there is about 10 euros extra on top of that. GPs are independent healthcare entrepreneurs, so they are not, we're not in an NHS-like system. We are in a different system where healthcare insurers play a key role. They make contracts with GPs, and it's not the central government that does that. There is a relatively small role for the central government there. I just want to also go briefly through why is it useful to use EHR data from primary care. Well, of course, it is the first point of contact with the healthcare system. There is a dense network of services. It covers all morbidity. It is routinely available. It's a professional health assessment. It's cheaper than health interview surveys and also health measurements with people. You have an epidemiological denominator, and it is longitudinal. I'm sure you're aware of this because many of you are doctors. How many doctors do we have? Hands? Well, there are quite a few other people. Who are the other people? Engineers, ICT people, lawyers, okay. People from the government? Nobody? Okay. So this is what we do. We maintain a website. We provide feedback portal for the participating practices, and we do a lot of research projects. The last time I counted the publications, we had about 600 publications in peer-reviewed journals since 2001. And what we try to do is establish what we could call a learning health system. And I need a pointer here. This is the pointer? Yeah. Except that it doesn't. Yeah, there. So we have the health services here that provide data, and what we do is research in terms of health monitoring, health services research and surveillance. We feed back that to the practices so that they can improve their care, and we feed that into knowledge that is translated in journals as peer-reviewed articles, and that can be taken on and be implemented in professional guidelines in general practice, for example. But it also goes to the health politicians, and these influence, of course, the health services again, and then they collect new data, etc., etc. So this is the circle we want to make. And, we do succeed at some of these things, and I will show you a few things about that. The data first is we have a representative sample of 500 practices representing 1.6 million patients, which is about 10% of the population. Between brackets there's a whole list of other services that we have data from. That's the GP out-of-hours services, primary care psychologists, physiotherapists, dietitians, pharmacies, and new in 2016, we're going to collect data from primary care nurses. And we are all going to link this data on a project basis. This is not a permanent linkage project. We do that on a project basis. what is in the GP electronic health records. That is, health problems, consultations, prescriptions, referrals, diagnostic test results, claims, and regarding the patient's year of birth, 4-digit postcodes, and gender. And we use only coded data, not free text. We can link this data to a number of other databases within Nivel primary care databases, but also external, and we can also collect additional information from patients. I'm not going to go into that because of the time. The rest of this presentation is, as I said, focusing on trust. And I go through a number of subjects that are very important to take care of when you want to create trust in the population, in the society as a whole, in a system like we have. And that relates to the privacy protection measures, data quality, governance and funding, the reasons for practices to participate, the reasons for patients not to opt out, and the ICT challenges. And I have two or three slides on each of these subjects. First, privacy. We have anonymous data through pseudonyms. Simon, would you approve of that? This terminology. It is difficult to get this message across that you can have anonymous data, but you can still link data from different sources. What I use in talks like this is that we have anonymous data through pseudonyms. These pseudonymized data in the Netherlands are not regarded as personal data. And that is very important because that means that we do not need explicit consent of patients to use this data. But the patients need to be informed very carefully, and they have to have an option to opt out of the system. And that's very important in terms of trust, in terms of privacy. This is a very technical picture that's coming from a publication that I worked on together with a number of other people that are participating in the Transform project. It basically describes 3 zones. It's the care zone where the doctor sits, is the physician, and he records data in a local database. This data is sent in through two streams to Nivel, where there is the non-care domain. This is the care domain, this is the non-care domain, and we have 2 databases. This is a pseudonymized database, this is also a pseudonymized database, but in this database there's no real data in terms of numbers of consultations or ICPC codes or whatever. This is just a pseudonym plus a number that is meaningful in this domain. So this allows us to go back to the practices and ask a patient, for example, to participate in an additional study. The primary care electronic health record data themselves are in database A, and these 2 databases can be linked through a trusted third party. Very important here also is to mention that before researchers can use data from our database, there is a privacy filter between our database and the database that they are allowed to use, in order to avoid that different researchers will combine B1 with B2 and 3 and 4, etc., etc. It will be very difficult to really prevent that, but it makes it more difficult for researchers to do that. So this is a very important privacy step. This is a very important privacy step, and this too, here's also a pseudonymization process going on. Later, after my presentation, you can ask, or you can come to me and ask more things about it. I think you are struggling with problems like this, and this is a solution we came up with, and maybe it can work in Italy as well. Data quality then. We have an extensive set of data quality filters focusing on the completeness of the data. Correctness is another aspect of quality. And we have practice feedback to make practices aware of their recording habits. And this feedback looks like this. Because of the time, I cannot talk about this much longer. But this is a graph representing all the practices in our system and giving the percentage of episodes with an ICPC code recorded. Governance and funding, this is also very important for you, perhaps, in your discussions with governmental bodies. We are funded by the Ministry of Health, but the Ministry of Health does not have anything to say about the use of the data. All the requests for data or research projects have to be approved by the professional organizations, including the GP professional organizations. And this is very important. They held back. They didn't want to play any role there. The only thing that we had to promise them is that if they ask something, an answer should be given, if it is possible, if you understand what I mean. This is our governance model, which I'm not going to discuss now. ICT challenges are not simple. We have 8 software packages, and for the general practitioners alone, for the physiotherapy, there's 10. Out of our services, 3. And all these software packages deliver data in different formats, so that we have to combine that into one database, etc. And also the pseudonymization is a challenge. This is a very important slide describing all the steps that the data go through. From the delivery of care, something must be recorded, then it must be extracted from an EHR system, then it must be translated into one database, then then data sets must be prepared for researchers, and then you can get research outcomes. And in each of these steps, it is very important to realize that something can go wrong in terms of data quality, in terms of validity of the data, and that is perhaps the same thing that Simon tried to point out, the difference between the ICT people and the researchers and the practitioners. You have to have the complete picture of this whole sequence of events in order to be able to control everything that is threatening the quality of the data. We give feedback to practices. We don't give money. At the societal level, reasons for practitioners to participate is that they want to show to the world, to the society, that they have an important role in the healthcare system, and they want to contribute to the common good. Also very important, there's no extra requirements in terms of work. You don't have to do anything extra to participate in this network. We have a feedback portal, which I'm not going to discuss. It gives information about consultations, type of consultations, quality of care indicators, quality of data recording, and health problems. Regarding patients, we have very few patients that wanted to opt out, and we're very happy with that. We do not want to change that, but there is a tendency of patients to regard their data as their property. And one important task for us is to make patients aware of the fact that their data is not their data. If everybody sticks to their data, we're back into the Middle Ages. We cannot use the experiences of patients and share their experiences and bring medicine to a higher level. So the patients need to be aware of the benefits for society, and that they are an individual within a society, and they need to be solidary with other patients and share the information that is collected about their health problems. But we do have also to maintain the opt-out option, and we do have to tell the patients what we are doing with the data. We need to tell them what we are doing and how we are doing it and for what purposes we are doing it. And this is, this is almost my last slide. This is, it is all about trust. It is trust regarding governance and funding. The pillars of trust are governance of funding and funding, data quality, privacy protection measures, and patient transparency, etc., etc. All the things that I discussed basically relate to the principle of trust. And this is my last slide. This is about the meaning of trust in Italy and the Netherlands. I found that this is just a newspaper. Gone in a minute, if you understand what I mean. On the other side, there's Italy, and Nigeria is the most, and so many Arabic countries and Asian countries are very far on the right-hand side, where trust is not driven by tasks, but driven by relations, and, for example, eating with friends and colleagues in Verona when you come from the Netherlands, and drinking Valpolicella. And that is more about trust in Italy than it is about trust in the Netherlands. So this is something we can talk about, whether the pillars of trust that I just described are the same in Italy as they are in the Netherlands. Thank you very much for your attention.
Grazie ai due relatori. Please, Simon, just, we are late, siamo in ritardo di mezz'ora, brutta notizia, e se calcoliamo che abbiamo 10 minuti avremmo 5 domande e 5 risposte, ma dobbiamo andare a 3-4 domande e al massimo 3-4 risposte. Quindi c'è qualcuno dal pubblico che...
Ah, perché l'ho già scritto.
What's the question? Stefano Alice, medico medicina generale Genova. Ha fatto la domanda. What was the question?
Shall I read out the question first? The question I got as a written question is, the question goes, this stuff simply doesn't work. Why do you think so many silly technologies have had so many problems?
Stefano, vuoi dire in italiano?
Sì, ho chiesto di questa cosa molto semplicemente dalla sua relazione si capisce che non funziona. Quindi è abbastanza sorprendente vedere che comunque molti tecnici ci sperino così tanto. Sono solo sciocchi?
My answer is that I think you have to see the context of those trying to manage the health system. In England, because of an increased older population who have many more comorbidities and health needs, and raising healthcare costs, we as a country can't sustain our level of healthcare to the expected trends in population and comorbidity. So there's a big driver to do something different. And I think what happens at the government level is they can see the demographic time bomb, as we call it, coming towards them like a headlight of an oncoming train, and a very plausible consultant comes in and says, it's easy, just give me £40 million, and the problem is solved. And if they come and talk to me or someone like Robert, we say, well, this can be done, but it's all rather complicated. And they think, typical academic, you know, they're not in the real world. And so I think those pressures make people opt for, if you like, what I call magical thinking. If I was to take you back to the early thinking in informatics, there was a lady who I think was the first female professor in Harvard Business School, and her name was Zuboff. And Zuboff is accredited with forming the word informatics, to informate. And the thing that she conceptualized in her sort of landmark book was the idea that you shouldn't think about technology as automating a process, that actually through using technology and automating a process, you develop a new process whom actors, people have to interact with differently, and new products. And she called that process to informate. And I think there's a lot of parallels between this idea of informating not being automating the old problem and the socio-technical work of Mark Berg and others that I alluded to in my talk. So I think with this, we as a profession have to be willing to experiment, but we have to open our eyes to the fact that if we bring technology into a process, it becomes a different process. It becomes an informated process with different consequences. And governments don't want to sign up to something that might have unexpected and unintended consequences.
Thank you.
Well, my name is Fausto Brini. I'm a local DP. Appreciated very much what you said, Valpolicelli included. But let me ask you a simple and quick question. Who does the data entry?
Who does the data?
Both of you.
Did you ask who does the data belong to?
What? Data entry. Who does data entry?
Who does the data entry?
Vuoi dire in italiano, Fausto?
Sì, gli ho chiesto chi mette dentro I dati.
Okay. In primary care, the data entry is primarily done by the physician. So because I was building my own computer system back in the 1990s, since the 1990s, I've been talking to a patient, writing a bit, talking to a patient, writing a bit. And I can almost prescribe, I probably worry I'm not safe, but I can almost prescribe a common antibiotic with only the quickest look at the screen. So in the primary care consultation, yeah.
I think you don't need a scribe, like in the US. Do you need a scribe?
You don't, but there are some important differences between hospital work and office-based work. So if you have an office-based specialty like primary care, it's very easy for the physician and the computer and the physician to make the data entry. I think it's been found to be much more challenging, for example, in the hospital environment, where yes, in the outpatients clinic...
Exactly. No, it's not referring to the... No, to be silence. No, just was asking silence.
Okay, right. I think it's much more challenging in the hospital environment, where in the clinic you can easily use a computer, but to do a ward round, or in the operating theatre, although people are starting to try and work out clean procedures and clean ways of doing these things, it's much more challenging to do. The biggest challenge, I think, though, we have to face is how patients can also, and their carers can also enter into the medical record. The best example where that's happening positively in England is for renal dialysis patients. So patients with kidney failure on dialysis, there's a thing called renal patient view. And it appears that about a third of patients, and this is quite an interesting group because most people who have dialysis are quite old, about a third of patients log on to this and follow their biochemistry and things quite closely of how their dialysis, their dry rate is going, and annotate it with questions that they want to ask the physician. And one of the areas which is a real challenge is both how we communicate with patients via those records in a sort of more Facebook-like way, and also how we might incorporate data from wearable devices or devices people make data. Links. So overnight, or really within a year, lab links was completely adopted. Another very positive one, because I wrote them, was that one of my interests is quality improvement in people with kidney disease. And I've been very interested in chronic kidney disease, really, as a way of identifying high-risk people with hypertension and diabetes. We wrote a CKD quality indicator. CKD had never been heard of really in UK general practice, and with about 18 months, about half the people with that condition were recognised, computerised, having their renal function tested. I think that was profoundly of health benefit. But there are some absolutely rubbish bits, which when the video goes out, I can see someone sending me some rude notes about, but I'll risk it anyway. Some of the absolute rubbish bits are we're supposed to do on COPD, people with chronic obstructive pulmonary disease, spirometry testing in primary care. I don't know any good evidence base for that being reliable, and I'll wait for the hate mail to arrive about that. Another thing that was rubbish was that they changed the codes that allowed you to have diabetes. So from 2004 to 2006, any of the diabetes chapter C10 in our read code system was allowed to have diabetes. And then on the 1st of April 2006, you only got paid if you used a C10E code, one code for type 1 diabetes, C10F for type 2 diabetes. Overnight, the prevalence of diabetes in the UK fell, and we had lots of people sort of recoded by practice administrative staff, type 2 diabetes on insulin, coded as type 1, so they got the wrong target. So it's had rubbish effects because you have to monitor people with asthma diagnosis, which are important to have flagged because not everyone's asthma is active all the time, had to be active asthma. So there have been, from my point of view, rubbish things, there have been good things, I would take a neutral view. You've just got to understand the context, and if it's going to come with some investment into Italian primary care, just make sure you get the investment and some good as well as some bad with it.
Okay. Thank you very much.